it's challenging to find a real case of IgG4-related disease because there is so much mimicker of the disease. Actually, there was just anecdotally saying that in most of the IgG4-related disease clinic, up to 60% of the people that are referred for IgG4-related disease end up being something else.
That's Dr. Hugues Allard-Chamard. He's a rheumatologist and assistant professor at the University of Sherbrooke, where his research focuses on immunology and IgG4-related disease. He's our guest on Around the Room, a podcast brought to you by the Canadian Rheumatology Association. Welcome back. I'm Daniel Ennis, and unfortunately, Janet Pope will not be joining us on this episode, so you're all stuck with me for today. Before we get to our guests, I want to announce some upcoming episodes on a whole bunch of interesting topics. These are going to include Sjogren's disease, auto-inflammatory diseases, and more episodes of Clinical Pearls, where you can submit cases to us to listen to us bumble through them. If you have questions you would like answered by the experts, please contact us through the CRA Twitter account at CRASCRRoom or by email info@room.ca. For our Clinical Pearls episodes, please get in touch if you have challenging cases you want to present on the podcast. Now on with our show and our guest, Dr. Allard-Chamard. Hugues, welcome to Around the Room.
Many thanks for having me.
We're really excited to chat. So you've actually hosted a French language version of this podcast, and I understand there's going to be a few in the works down the road, so I'm excited to hear about those as well. But today we are going to pick your brain about IgG4-related disease. You ready to chat about that?
Yes, of course.
Okay, fabulous. So to begin, I'd like to set the table for listeners with what I think is a pretty fundamental question, and it may sound easy, but perhaps it's more complicated. What is IgG4-related disease?
Yes, actually, as you said, it might look like an easy question now, but we have to realize that IgG4-related disease is kind of a new disease because although it has been there for a very long time, we're not able to pick all the cue and put it together as a whole entity. So I think the first description we have in the literature date back from 1888 from a surgeon, Mimicker, who described the first patient with swollen gland in the ENT sphere. But really, we started to have a better understanding of what could be IgG4-related disease in 2001, where a group of Japanese made the association between type 1 autoimmune pancreatitis and elevated IgG4 in the blood. And then the disease kind of was born in 2006. So I'm kind of escaping your question. So what is it really? So in the end, IgG4-related disease is a fibroinflammatory disease with plasmablast infiltrating organs that could be associated with elevated IgG4, but not always. But it is a feature, at least on the pathology.
And why is it important to distinguish it as a fibroinflammatory disease versus, lumping it in with the other autoimmune diseases that we tend to see, or autoinflammatory diseases? What makes it fundamentally different than those?
Well, I think it's its own entity with its own evolution, and it's definitively challenging to find a real case of IgG4-related disease because there is so much mimicker of the disease. Mm-hmm. Actually, there was just anecdotally saying that in most of the IgG4-related disease clinic, up to 60% of the people that are referred for IgG4-related disease end up being something else.
Oh, wow.
So there are plenty of mimickers. But when you find it and it's really IgG4-related disease, usually the treatment is relatively easy. It's a disease that responds fairly well to a glucocorticoid, for instance. So I think it's important because the set of treatment is different. Mm-hmm. The evolution is different. And yes, we can definitively change the course of this disease by our treatment.
I see. So that kind of then leads nicely into my next question, which is, can you kind of describe to us the clinical spectrum of the disease that you see in your clinic? What are the phenotypes we should be looking for clinically?
It kind of goes into two things. How do we make the diagnostic and what can we expect to find? So I'll start by saying that if you go back and look at the classification criteria, which I won't go through all the classification because it would be too long, but it's a 3-step classification, and I think it's helping us to a bit understand what we should be expecting or not.
Mm-hmm.
So the first, that is kind of an inclusion criteria. You must have a fibroinflammatory mass somewhere or retroperitoneum fibrosis. So you must have one of these fibroinflammatory masses somewhere. Then you kind of have a bunch of exclusion criteria. So for instance, patient must not have cytopenia, not have fever, not have feature of Castleman disease, not have feature of Erdheim-Chester, and so on. So you must thoroughly make sure that it's not another Mimicker. And then the third part is a score. So you combine serologic, pathologic, and by organ manifestation. You lump all of that together and it will give you the likelihood of you being facing IgG4-related disease.
Mm-hmm.
But when we take all the patients that successfully are classified as IgG4-related disease, we really have 4 different type of presentation. So we have the pancreatico-hepatobiliary manifestation with the type 1 pancreatitis. So that is the main manifestation. Then there is the group 2 where we have retroperitoneum fibrosis and arthritis, and this kind of manifestation. Then we have the type 3, which is the head and neck limited disease, which was actually one of the first group that was discovered because it was mimicking Sjogren. So these were patients, they were ANA negative, but with the profound sicca and swollen of the ENT gland. So that's the third subset. And then we have a fourth subset, which is called Mikulicz syndrome and systemic. These patients present and are the one that people that kind of tend to mark people mind because they have fibroinflammatory masses a bit everywhere. They're a bit more florid. They have more IgG4 in the blood. They are a bit more severe. So that's the fourth type that we can have. As I always point out, this disease has been only known for a few years. And why is that? Because it is very pleomorphic in its manifestation and presentation. So one should not stop and saying it should look like that. There are criteria that comes more often, obviously, but we have to keep in mind that there might be more manifestation. And speaking to that, when we take these patients, when we do TEP scan, in 80% of the cases, we find additional fibroinflammatory masses somewhere else that was asymptomatic at time of diagnostic. So we don't do PET scan on everybody, obviously, but just speaking that we definitively have manifestation throughout the body.
So these phenotypes are kind of conceptual. They are common that certain symptoms and certain organ involvement do pool together, but it's not exclusive in that you can't have involvement of the pancreas and no involvement of some of the other organs you mentioned. It's just that there's a likelihood that these things pool together. Is that fair?
Yeah, that's exactly, I think, how we should conceive this classification.
Okay.
Nothing is mutually exclusive, but something tend to cluster together more frequently.
And you went through the classification criteria, and I'm wondering if you can kind of give us a bit of a sense about how you actually work up the disease in terms of, do you have kind of a standard laboratory approach? Are there common things that you alluded to mimic? So are there common things that you look for in your preliminary blood work that a rheumatologist should take away from this discussion as, if I'm looking for IgG4 disease, I must check tests 1, 2, 3. These must be done. Anything that you can kind of give us to add to our order sets?
Yes, so there are plenty of things that you can find in the blood, definitively, but I always start with a complete blood count because usually you should not have cytopenia, and eosinophilia can be present but should not be above 3,000 per milliliter square. because one of the things is that EGPA can be a mimicker of IgG4-related disease. So there is kind of this narrow. You can have some eosinophil, but not too much. If you have too much, you must think of something else. Usually, depending on the clinical manifestation, you must rule out Sjogren, sarcoidosis, and all the ANCA-related vasculitis. So it's not in every case, but most of the case, we have to rule these diseases out. I always make a panel to make sure that the kidney are working properly, because we can have tubulointerstitial and nephritis, and there is a lot of GI manifestation, so always make sure that your liver function are good. Then I check for complement. So a lot of these patients, especially the patient with kidney involvement, will be hypocomplementemic, so that kind of give me another additional thing to look at. When they are hypocomplementemic, I do my cryoglobulin to make sure that it's not, well, it does not give fibroinflammatory masses, but you never know if it was a lymphoma, for instance, with cryoglobulin. Then you need to be a bit creative to be sure that you're not having one of this mimicker in front of you. Then the total IgG are usually high, and then IgG4 might be high, not 100% of the time, but I definitively will check it.
And can you give us a bit of a range on that? So how often is the IgG4 actually elevated? Does it matter if all of the IgG subclasses are elevated? So is there a ratio that we should use? And what's the typical range that we're looking at for this disease? What should we usually bump into if we're actually diagnosing it?
It depends of the subset of, when I say that there's 4 kind of phenotypic IgG4 that you can come across. So usually what we notice is the type 4. So the systemic one have the highest IgG4 in the blood, and the patient with retroperitoneal fibrosis and aortitis are the ones that are the most likely to do not have elevated IgG4. So I don't have a number for every on top of my head, but what I can tell you is when we do the classification of the patient, if you have some elevation above 5 times the upper limit, that gives you a lot of point toward classification as IgG4-related disease. And usually we tend to say that you need to have at least 2 times to consider IgG4-related disease. Also, although some won't have, but it kind of help to categorize patient. The other thing that I want to point out when we're talking about elevated IgG4 in the blood is that any chronic inflammatory disease will lead to some increase in IgG4 at some point. So when the classic, if you have a long-standing RA patient, you might have elevated IgG4 in the blood, but usually it will be in the 2-fold. It will not be 10-fold, the upper limit. So this is why we have this kind of gradation in the classification criteria. And overall, if you take all the patients together, it's roughly 20% of the patient that will have IgG4-related disease that will have IgG4 that are below 2 times the upper limit of the normal.
So certainly not a perfectly sensitive test, and even when it's elevated, not a perfectly specific test. We still have to contextualize it. We still have to do the clinical work of going through the exclusion criteria and all of that. So, further to this point, if you have a patient who you suspect the disease in, I'm wondering what tissue would be best to biopsy. Is the retroperitoneal fibrosis, if it's amenable, are you going to get lots of information there, or should you look elsewhere?
Yeah, so it really depends of where are your masses. So I will say that lymph node, ENT gland that are swollen are usually way easier to biopsy. Often I would say that in the process, sometimes we have to come across lymphoma. So sometimes we have more argument to go and take a little piece of somewhere. But when it's arthritis and retroperitoneum fibrosis, often the yield of the biopsy is not good, and we have to assume at some point if we cannot have, because these are biopsies that are not easy to perform. The risk of complication is relatively high, and often for retroperitoneum fibrosis and for lymph node, we don't have the full pathology of IgG4-related disease. So we have to be a bit mindful when we submit patient to biopsy that the yield might not be as high as we would have liked. If we compare to a fibroinflammatory mass on one kidney, to say something. These are usually more typical of pathologically, at least.
If you're going for a lymph node, are you happy with fine needle aspirate or core biopsies, or do you require the excisional biopsy to really get the architecture?
I think the architecture is kind of crucial because we will look at a few things, and one of the exclusion criteria is it must not be Castleman disease, which Castleman disease can literally mimic on the pathology almost all the feature of IgG4-related disease, but you must do all your workup for Castleman disease, and you need to find these I don't know how you call them in English, but the onion skin lesion with the artery that is going to the center. So that on needle aspiration is very hard to see. And one of the features of IgG4-related disease, that is the storiform fibrosis, which is not easy to see from the start. So in a lymph node, it's even harder to see. So if you want to maximize your chance of not having to submit your patient to multiple biopsies, probably good to go for the real one from the start.
Good to know. So once you've decided on a tissue to biopsy and you actually biopsy it, what do you actually see?
Yes. So first of all, I'll try to say that I try to avoid the lymph node if I can, because there's a lot of, it's not as specific in the lymph node as in the other organ. If you have to venture there, then definitively do it. It's helpful to eliminate all the hematologic malignancy and so on. But if you're able to have a good fibroinflammatory mass, what you'll see is that you'll have a very marked lymphocyte and plasmacyte infiltration and fibrosis in the tissue. As I was mentioning, you should have a fibrosis that is called a storiform fibrosis, and often it's not easy for the pathologist to decide if it's storiform or not. But what we have to remember about this fibrosis, it is a fibrosis that is not organized. All the fibers are not in the same direction. So sometimes it is one of the fibers that can disappear more easily with treatment. Then we have to go and look for obliterative phlebitis. That if it's not mentioned, you have to look if your pathologist has stained the elastin. That's the easiest way to see it. So you'll see the border of the vessel with the elastin staining, and you'll see all the cells that are invading inside the vessel. And lastly, I think IgG4 is to be stained. So there has been a bit of a debate on what is the cutoff that should be used, and I think it's probably depending of the organ in which we are looking. But I would say that usually if we have more than 10 IgG4 positive lymphocyte per high power field, or more than 50% of the IgG positive lymphocyte are IgG4, so 40%. These are usually good sign that it's probably IgG4 related disease, but you still have to go through eliminating all the mimickers.
We've kind of been alluding to these things throughout our discussion here, but I'm wondering if you can kind of give me a little bit of a list of in your clinic where you're seeing 60% of people referred are actually end up not being IgG4 related disease, what do they typically end up being? Like, what are the common mimics that you're seeing? You've alluded to some unusual diseases already.
Yeah, so we do see plenty of mimicker, but I think if I go for more rheumatologic mimicker, so vasculitis can definitively be things that could mimic and could give you masses in a distribution that could look like IgG4-related disease. You can have the ENT involvement, sarcoidosis, also could give us these features. Then there are some hematologic malignancy that can definitively be a problem. I will go back to Castleman just because it mimic almost all the aspects. So we have to be very careful. But there are other malignancy that could give the change for IgG4-related disease. Some long-standing infection like Epstein-Barr-related lymphadenopathy could be confounding. On more of the GI side, so inflammatory bowel disease, when it's long-standing, can increase the IgG4, can give you pancreatitis. It kind of have a lot of things that could be mimicking. Some histiocytosis, especially the Erdheim-Chester, will increase the IgG4, can mimic almost everything, but usually you'll have the hairy kidney and the involvement of the long bone, so you can make the difference. Mm-hmm. And one of the last one that I think I must point out for the rheumatologist is called the myofibroblastic inflammatory tumor, which is something that we don't often hear, but I think it's important to become a bit more familiar with this disease. So it's a disease that we often see in younger individual, and it can create fibroinflammatory masses, one or a few. It is usually in the thorax, and if you do the biopsy, it literally can have all the feature of IgG4 on the biopsy, so elevated IgG4, storiform fibrosis, and so on. And you need to ask for anaplastic lymphoma kinase 1 staining to find that it's a tumor. It's a locally invasive tumor, and it will be not responsive to your first treatment with glucocorticoid. So this is, I wouldn't say the most frequent mimicker, but definitively one that if you don't look for, you can get in trouble later down the road.
Okay, great, thank you. And you've teed up our next subject here, which is treatment, and you've made the point already that this fibroinflammatory disease is kind of by its nature steroid responsive. Failure to respond actually makes you wonder if you're really treating IgG4 disease. So let's kind of start from maybe the beginning. How are we supposed to be treating IgG4 disease? Does everyone require treatment? Only some people? Maybe just starting there, and then we'll kind of tick through some of the tried and tested treatments.
I think most people with systemic involvement will end up requiring some treatment. When it's very limited, when it does not impact quality of life, I think we can be monitoring the disease, but always keeping in mind that you can have manifestations that are a bit more medically involving. Like if you have the pancreatitis, you cannot do 50 of them in your lifetime. So I think that if you have one, then we're more prone to treat patient. So in the end, unless they have very limited ENT manifestation, I end up treating most of my patients. Usually I start my treatment with prednisone, 0.6 to 1 milligram per kilogram daily. And then after 2 to 4 weeks, I will start the tapering at a rhythm of probably 5 milligram every 1 to 2 weeks. Depending on the original burden of the disease, I will try to tailor it. And we so far have no guidelines that are very well defined telling us how long we will have to treat patient. But one thing I will point out is When we go back in the registry, and these are Japanese data, but after 1 year of treatment where they were tapering patient from 3 to 6 months, they had only 61% of the patient that were in remission. So barely, what it means is 40% of the patient relapse. So it is a disease that tends to come back. So you have to be monitoring the disease. Then usually what I do is I give them one chance to do one relapse. And then I just go back to the corticosteroid therapy. And if they are doing more than one relapse, then we have to think of advanced therapy.
And so that sets things up nicely. One thing that I noticed is that IgG4 disease actually does have some literature on the steroid dosing, which we don't have necessarily great, RCTs or even, prospective or retrospective stuff in some of our other diseases to say, can we get away with low, medium, or high doses of prednisone? There is some literature in IgG4 that attempts to answer some of those questions. So that's quite helpful. When you reach for a DMARD or a second steroid-sparing agent, can you kind of walk me through the process of which ones you choose and why?
Right now we have a plethora of case series and case report with a lot of our DMARDs that have been used relatively successfully. So azathioprine, MMF, methotrexate, leflunomide, and rituximab. And for me, and I might be a bit biased because my research were on B-cell role in IgG4-related disease. But usually I will go for rituximab because it's very effective. And as we understand this disease, the plasmablast and the activated B cell are really at the core of this disease. So when you remove them from the equation, usually patient will go in remission relatively rapidly. And we have very, very few refractory cases of patients that were not able to be successfully treated with rituximab. Usually the reason why we have to go for another line of treatment after rituximab is because they develop allergy or they have serious reaction to rituximab. Then we cannot use it anymore, and then we have to go for something else. So this is how usually I manage.
And if you have to go for something else, or rituximab is not going to be available to you, of the other ones that you mentioned, I'm curious what you reach for first. I'm aware of RCTs of leflunomide and MMF, but I'm wondering, you also mentioned azathioprine and methotrexate. So how do you choose between all these things?
Yeah, so I think these are all relatively non-specific immunomodulatory drugs that are not specifically targeting the B cell, which are at the core of this process. One of the things that we end up discovering is that there are some set of T cells that are also involved in this disease, which are the cytotoxic CD4 T cell. So usually, and that might be a personal preference, I will go for methotrexate or MMF first. I think I'm used to these drug, and for patients who had mild manifestation, I think it's good. But I'm aware of the RCT with leflunomide. Also, I just didn't have the chance to use it on a regular basis. As often where I'm practicing in Quebec, we do have good access to rituximab. So I rarely have to go around and not use it.
I see. And just along the lines of the T cells involvement in the disease, I believe that you were involved in a prospective study on Abatacept for IgG4 disease. Can you kind of comment on the results that you found there?
Yeah, the study has been published actually, and it seems to be an option for patients who are not able to undergo rituximab therapy. But maybe I should just quickly review what we think is at the core of this disease and why we thought that Abatacept could be of use in this disease. So although we don't know what is starting the disease, one of the things that we know is that in the fibroinflammatory masses that we have, there are infiltration of plasmablasts and a lot of B cells that are IgG4 positive. And in the tissue, these B cells end up working as antigen presenting cell, and they activate cytotoxic CD4 T cell who are responsible for a lot of the damages that we have in the tissue. So where we could act is we can either remove the B cell, which is what we do with rituximab. And one of the things that was surprising for us when we studied these patients is when you use rituximab, 1 week after, the CD4 cytotoxic T cell vanished also. So they seem to be very depending on the antigen presentation from the B cell. But when you cannot deplete the B cell, the other thing that you can do is block the interaction between the plasmablast and the T cell. And this is what Abatacept is doing. So this is why we venture in exploring if this drug can be used. And it has some efficacy, and it can block this interaction and help to relieve patient symptoms.
Okay, great. And because we're leaving treatment, I'd be remiss if I didn't mention Dr. Molly Carruthers, who was, I believe, the lead author on that prospective rituximab trial from 2015. That's kind of contributed to its use for IgG4 disease, and she works out here, so I wanted to make sure I mention her. Okay, so now moving on, looking forward, what's in the pipeline for IgG4 disease? What can we look forward to in the coming years in terms of diagnostics or treatment?
So I think we'll get a better understanding of what is IgG4-related disease and what is the role of IgG4 in the disease. Maybe two things to say about that is when you look at the IgG4 that are produced and you sequence them and you look at their clonality, what people have noticed is that there is an oligoclonal expansion of IgG4. And you might not be familiar with the meaning of having this oligoclonal expansion, but it is something that we see when the immune system is facing one antigen or one pathogen. So what it has led people to think is that, like in other disease like NMO, there might be one antigen that is underlying IgG4 related disease development. So people are actively looking at antigen that could be responsible for the disease. So the other thing that I think we'll see coming is what is the real contribution of IgG4 to the IgG4 related disease. And we have some data that are now in mice, so we always have to take them with a grain of salt. But based on the data that we have in mouse, we do know that IgG4 are anti-inflammatory IgGs that are upregulated with chronic inflammation, and they serve to protect from damages that could be performed by other immunoglobulin. And if you have a mouse model and you take the IgGs from patients with IgG4-related disease and you infuse IgG1, IgG2, 3, and 4, what you'll notice is that IgG1 can induce a lesion in the digestive tract that is kind of reminiscent of what we have in IgG4-related disease. And if you put these IgG1 and 4 at the same time, you have less damages. So it does look like the IgG4 is acting as an antigen sink to prevent further damages. So maybe they are not purely bystander as we thought originally. That has not been proved in human. It is mouse data so far. But I think that our comprehension of the role of IgG4 in IgG4-related disease will likely improve, and we'll have some more insight on the pathophysiology of the disease. In terms of treatment, I think we'll see other B cell depleting or B cell, I don't know how to call them, but impairing or disabling drug, and that will be used for IgG4-related disease. I am aware of a few trials that are on their way with a new mechanism of action trying to basically reduce the potency of B cell to activate the T cell in the tissue.
Well, great. Sounds like there's lots of interesting stuff on the way. So, before we let you leave, we're trying to get to know our guests a little bit better on the podcast. So we're asking them what book they're reading right now. So what's on your bedside table?
On my bedside table, and that's a good question. I don't have anything. I'm done. Actually, I was rereading The Lord of the Ring because there will be a new TV show that will be released where they will be exploring everything that happened before the books. So I was kind of rereading that to put all of that in my mind fresh and be able to follow while I will be watching the series.
That's a great idea. I just saw the first episode last night, so I won't ruin anything for you, but I think that you're doing the right thing by pre-reading. Great. Well, thank you so much for joining us today. It was a real pleasure to chat with you about a really interesting and evolving topic.
Well, thank you so much. It has been my pleasure.
That's it for this episode of Around the Room. For questions, comments, and future episode ideas, email us at info@room.ca or tag our Twitter account with your question at CRASCRroom. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Leslie Ishimwe. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. And of course, an extra special thanks to Dr. Hugues Allard-Chamard. Our theme music was composed by Aaron Fonwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. You can also share this podcast with your colleagues and spread the word on social media. I'm Daniel Ennis. Thanks so much for listening.